Ma'am, we are on live and we are starting session, ma'am.
Okay.
So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is diagnosis and management of dysmenorrhea. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Subasri ma'am. Madam has done her MBBS and MSOG. Madam is expert in obstetrics and gynecology, infertility specialist, endoscopic surgeon and sonologist. And Madam is currently associated with Sai Nursing Home. Madam has had a very vast experience of more than 11 years, and she has been in very various roles like assistant professor in Sri Ramchandra University, Chennai, assistant professor in Meenakshi Medical College, Kanjipuram, and resident at Manipal University and Jipmer, Pondicherry. And Madam is also a member of FOXY, Indian Medical Association, and World Association of Laparoscopic Surgeon. So with this short introduction, I welcome you, ma'am. Mandarin session to you for your presentation, ma'am. Welcome, ma'am.
Okay, thank you, sir. Thank you for your introduction. Good afternoon, everybody. Today I'm going to talk about dysmenorrhea and its management. Dysmenorrhea is a topic that's a huge topic actually. It's a common term coining about just painful menstruation. So every month there will be a pain during the periods. Usually the dysmenorrhea pain occurs during the periods and it may subsides at the end of the menstruation. So the commonest disorder of the female reproductive system, many a times it affects the adolescent girls from going to school and limits them in academic sports activities. And its incidence is 50 to 70%, but only severe in only 10% of the people. So we'll classify.
Can you make it in full screen mode, ma'am?
Yeah, it is already in full screen only, ma'am.
No, it's visible. It's not visible, ma'am.
For me, it is visible in the full screen.
Ma'am, it's not in the slide share. I can just stop sharing and reshare once again. Yeah, ma'am.
It is coming as you are screen sharing live, like that it is coming.
Okay, ma'am. You can start your presentation, ma'am.
So we classify dysmenorrhea into two types, primary and secondary. So primary dysmenorrhea is common in the adolescent age group, that is as soon as they attain menarche, within 6 months or 1 year of after attaining menarche, they get to dysmenorrhea, that we call it as primary dysmenorrhea, common between 17 to 22 years. And secondary dysmenorrhea is more common in elderly women. And secondary dysmenorrhea is most of congestive type, mostly may be associated with some pathological problems. So primary dysmenorrhea, what does it mean is, it is painful menstruation in the absence of any pelvic pathology. That means the uterus is absolutely fine. It's no pelvic pathology. It is common in nulliparous and young girls. It is associated with painful menstruation along with bleeding. It is usually colicky and crampy pain associated in the midline. It lasts for 12 hours up to 3 days of menstruation. Actually, longer than 32 hours, the pain won't be there in case of primary dysmenorrhea. And this we call it a spasmodic dysmenorrhea. So spasm is more common, and it starts 6 to 12 months, because first 6 to 12 months there will be anovulatory cycles. That's why usually it starts 6 to 12 months after menarche. And there is a positive, any family history, mother, sister having dysmenorrhea, they also used to get this kind of dysmenorrhea. So in the dysmenorrhea, you can see that duration. Usually,
slides are not moving, ma'am.
It's moving, no, sir. I'm seeing. If you want, I'll just take a video also and show.
1 second, ma'am. Let me check, ma'am. 1 second. It's not moving, ma'am.
Actually, for me, the slides are moving only, sir. And it is also coming as live screen sharing like that.
Okay, ma'am. Ma'am, you can stop sharing them once again. You can just reshare. Why? Because it is in the first slide, ma'am.
Okay.
Ma'am, it's in the first slide.
Yes, sir. Sir, you see here it is. Just coming as your screen sharing. Your screen sharing.
Perfect, ma'am. Now it's coming full screen. Thank you.
Ma'am, am I audible now, ma'am?
Yeah, yes, sir. You're audible, sir.
Yes, ma'am. Which slide you have to start, ma'am? I have to start from ma'am. This slide?
Yes, next
Yeah.
slide, sir.
Yeah, ma'am. Yes, ma'am.
So next slide.
Yes, ma'am.
So primary dysmenorrhea is most common in the starts at the first day of the period, and it lasts up to 3 days, and it is also called spasmodic dysmenorrhea. So the dysmenorrhea pain will be in the lower abdomen and may radiate to thighs and legs. It usually improves. Usually after marriage and delivery, the spasmodic dysmenorrhea or primary dysmenorrhea improves. There is secondary dysmenorrhea. It usually starts before. It is also called congestive dysmenorrhea. It usually starts few days before the periods and it lasts more than 3 days. It usually worsens with the age. So along with the dysmenorrhea, these people may get nausea, dizziness, headache, sometimes increased bowel movements, hip pain and back pain are also associated. Next slide. So the etiology is mainly due to increased prostaglandin secretion. So increased prostaglandin is secreted from the endometrial cells that causes vasoconstriction, causes blood flow ischemia, that is vasoconstriction of uterine blood vessels, causes uterine ischemia. That's why it causes debilitating cramps. And also it first hour of menses, the pain will be excessive. And also prostaglandins causes hypersensitization for painful stimulus. So many other behavioral, cultural, psychological factors also influence the pain. So this is the path it's showing whenever this corpus luteum, that is whenever the pregnancy doesn't occur, the corpus luteum regresses. Because of that, the progesterone secretion will decrease. So progesterone decrease causes withdrawal bleeding. It in turn stimulates prostaglandin and other metabolite secretion. So it causes the myometrial contraction, reduced blood flow, and increased sensitization of the pain nerves. So prostaglandin is the main culprit in case of this primary dysmenorrhea. Whenever the patient is not ovulating, then there won't be any secretion. That's why in anovulatory cycles, these girls won't get dysmenorrhea pain. Next slide. So this is the pathway. PGF2 alpha increases prostaglandin secretion, causes smooth muscle contraction and ischemia. Next slide. So the investigation that I'll tell in the next slide. Next slide. So how to manage is either we will give hormonal medications or non-hormonal. Non-hormonal is the main culprit is prostaglandin F2 alpha. So prostaglandin inhibitors we give. Prostaglandin inhibitors are mefenamic acid, naproxen, diclofenac, this kind of NSAIDs we are using. And hormonal is pills, oral contraceptive pills. or if they are married, we use progesterone containing IUDs. Next slide. So NSAID, I told it inhibits prostaglandin production. And oral contraceptive pill, next slide. So whenever this NSAIDs we give, then what is the side effects is, if we use for a long time or you give the excessive dosage, may cause gastric irritation, nausea, so nephrotoxic if you are using higher dosage. And some people may develop hypersensitivity for mefenamic acid, headache, blurred vision, bronchospasm in asthmatic, and hypersensitivity reactions are side effects of NSAIDs. Next slide. So OC pills. So whenever NSAID fail or contraindicated, we are giving oral contraceptive pills. That's 90% effective. As you all know, it inhibits ovulation, so this prostaglandin production is not there. That's why there is a great relief of dysmenorrhea when we give OC pills. Next slide. So decreases prostaglandin and decreases endometrial thickness. Next slide. So if these measures fail, so these are rarely done. Like either we give non-hormonal or hormonal treatment. Very rarely, whenever the lady is in case of secondary dysmenorrhea, what we will do is presacral neurectomy, that is knocking out the presacral plexus from where the pain signal occurs. This is the treatment last resort when other measures fail. With cervical dilatation, usually when we do it, in case of like infertile patients, severe pain, that we will do. Otherwise, routinely we won't do cervical dilatation and nulliparous. Next slide. So not only the pain thing, we have to follow our other lifestyle modifications like regular exercises, avoiding stress during periods, and also you should avoid lack of sleep, gentle abdominal massage, yoga and other exercises will definitely help in dysmenorrhea. Next slide. So these are all natural remedies. So these are all natural remedies like ginger, yoga, mint, and aloe vera, balanced diet, cinnamon, beetroot. These are found to have some beneficial effects when we use during periods. Next slide. So these are the investigations. First, initially, whenever adolescent girl comes, we give normally NSAIDs and see how they respond. If they are not responding, then we go and do ultrasound scan for them to look out any uterine anomaly, any abscess or endometriosis, and we'll do just complete blood count and CRP to look for any pelvic inflammatory disease. Whenever patient complains of white discharge, we take swabs to rule out infections. CA-125 also we be done in case of endometriosis. And when we find any polyps or fibroids, then we'll go on to hysteroscopy to remove them. And also in the suspected case of endometriosis, pelvic adhesions, we do laparoscopy. Is for diagnostic as well as treatment purpose. Next slide. So secondary dysmenorrhea, there will be an underlying disease of pelvic organs. We have to correct the problem. Primary only we'll give medical management. Next slide. So these are all causes of secondary dysmenorrhea. Gynecological, non-gynecology. So gynecological is endometriosis, congenital abnormalities, STD, PID, adenomyosis, uterine fibroids, and cervical stenosis. Non-gynecological causes like pelvic floor dysfunction, irritable bowel syndrome, that may mimic dysmenorrhea, bladder pain syndrome, pelvic adhesions, and inflammatory bowel disease. Next slide. So these are all the laparoscopic picture, how the endometriotic deposits. You see all blood clots outside the like uterus in the pelvic region. So we do laparoscopy to like cauterize all these deposits and remove it off. And then we followed by that, we'll give hormonal suppression for the endometriosis. Next slide. And this is the thing, whenever a adolescent girl, she comes with severe pain and she has, sometimes they may come with like periods pain, they will get severe dysmenorrhea, but they won't menstruate. They'll come with amenorrhea, primary amenorrhea. So we have to examine that hymen and local examination and ultrasound scan we have to do. Here we will see the hymen, imperforate hymen. We have to make a cruciate incision for this hymen to let out. So all the blood will be collected inside the vagina, cervix, and also in the uterus. It may extend up to the tube also. So if you clinically examine this lady, we can see the imperfect hymen. We have to do surgical correction for it. It's like, and this is laparoscopy. In this, we can even PID. We can see pelvic adhesions and any infection. We'll see the tubal enlargement. That is hydrosalpinx. Sometimes, whenever there is a hydrosalpinx, we will do excision, or else we'll take salpingotomy to let out the fluid, and we send the cultures for a PCR back tech to rule out any tuberculosis. The tubes are damaged, and maybe we end up in removing the tube also. So we have to treat it. If it proved to be a tuberculosis, we have to give a ATT. If it is simple PID, we can give antibiotics for the infection to subside. Next slide. So the diagnosis is, whenever we come to know the diagnosis by ultrasound, we'll treat it. If not, we can do even laparoscopy to diagnose. It's a gold standard to diagnose what is the cause for dysmenorrhea. So from the history, we'll come to know whether it is primary or secondary. And recurrent pelvic infections, we'll come to know by white discharge, fever, any IUCD usage, recent pelvic surgery, all may contribute to any infection. Sometimes whenever dysmenorrhea associated with heavy period, we have to look for any polyp or fibroid. Sometimes whenever there is infertility, dyspareunia as well as dysmenorrhea, we have to rule out endometriosis. So all 3Ds will be there, like dysmenorrhea, dyspareunia, disorders of menstruation. 3Ds more common in endometriosis. So pelvic examination is more important. So it may help. Whenever it is unmarried, we can do perectal examination to look for local examination of the hymen. Finally, we can do an ultrasound examination to find out. Next slide. So investigation, as I told you, complete blood count, swabs, we take ultrasound, detect fibroid, polyps, abscesses. Laparoscopy is both diagnostic and therapeutic. It's a gold standard treatment in endometriosis. And whenever we doesn't know the cause for pain, we'll do laparoscopy to find out the cause. And hysteroscopy, whenever there is a polyp or any submucosal fibroid or any intra-uterine adhesions, we'll do hysteroscopy. Even we take biopsy from the polyp. Next slide. So this is the treatment plan as whatever I told you to summarize here. So the history, onset of pain, and how many hours it lasts, and it is associated with diarrhea, vomiting, and all. So whenever the history is long, it lasts more than 3 days, and the pain doesn't subside with NSID, we have to treat like a secondary dysmenorrhea. So secondary dysmenorrhea usually will be associated with menorrhagia, and even after the period stops also, sometimes the pain will be there. Next slide. So PMS, it's a premenstrual syndrome. Usually it occurs after ovulation, that's in the luteal phase. That last 15 days of the cycle that we call is a luteal phase. During that phase, the patient used to get premenstrual symptoms again, mood irritability. It causes hindrance to work, blotting, and they even feel breast tenderness. So before the periods comes, they used to get some symptoms that may affect the day-to-day activity that we call as PMS, premenstrual syndrome. Next slide. So these are premenstrual syndrome is not only pain, headache, acne, mood swings. Next slide. So whatever I told only, bloated feeling, weight gain, edema, breast pain, tenderness, hot flushes, pelvic pain, change in bowel habits, muscle and joint pain. Emotionally, they feel more irritability, aggressive, because tension, anxiety, and depression. Next slide. So there are not many theories. Many people say it is due to hormonal imbalance. They put forth vitamin B6 deficiency. Most of the time they're telling psychological factors. Next slide. So whenever the ovulation occurs, whenever the progesterone is produced, the PMS occurs. So whatever the drugs we give to inhibit ovulation, like oral contraceptive pills that relieves the PMS, even vitamin B6, vitamin E, primrose oil, like that, many adjunctive measures are available to treat the PMS. Slide. So main treatment here is counseling and reassurance. Since the problem is mainly it affects their day-to-day activities, and if they do exercise, it will increase the endorphins, and they emotionally, if they feel happy, the PMS will decrease. And whenever there is a bloating, you can try diuretics and antiprostaglandin for any crampy pain. For breast tenderness, you can give bromocriptine or cabergoline or vitamin E, Primosa, like that. So ovulation suppression drugs are OC pills, Danazol, or continuous medroxyprogesterone. These are all medical management available. Next slide. So the bromocriptine, this tablet 2.5 milligram BD we give for last 15 days of the cycles to suppress, or else weekly once cabergoline 0.5 milligram we can give to suppress that breast pain and tenderness. Next slide. So danazol, primrose oil. This danazol has anti-estrogenic effects. So anti-estrogenic, androgenic all effects. So sometimes the danazol uses may cause atrophy and it increases the hot flashes. So danazol is not first mode, it's a last resort whenever they are not responding to a conventional treatment. Next slide. So dysmenorrhea, as we told you, we have to examine and we take history, ultrasound. Whenever it is no cause, it's only primary, we can give medical management. Only when there is infertility associated with dysmenorrhea, we will do surgical mode like laparoscopy and all. So secondary dysmenorrhea, initially the fibroid is small or whatever the pathological lesion is less, we'll give medical management. If not subsiding, then we resort for surgical treatment. Next slide. Next slide. So the take-home message is dysmenorrhea is highly prevalent in your family. If you take the 3 in 1 women will have this dysmenorrhea. So it mostly the positive family history, and also sometimes significant risk factors. Whenever the bleeding is more, the dysmenorrhea will be more. Lifestyle modification, and we have to ask the lady to seek medical attention whenever the pain is very severe, not responding to NSAIDs. And proper health education and menstrual hygiene has to be taught to young adolescent girls. Sometimes they may ignore the pain so that the some underlying pelvic pathology may increase in size. Sometimes it may end up in destructive surgeries also. So they have to meet a doctor if this dysmenorrhea is very severe, not responding to medical management. Next slide. Thank you. Thank you. Those who are having any doubt regarding this topic, you can ask me. Yes, sir.
Ma'am, chocolates, some studies are saying that you can use these chocolates to reduce the cramps in this dysmenorrhea, ma'am.
So all are like endorphin release, sir. If you are happy, they are telling no. If you are happy, the endorphin hormone is secreted. Like chocolate also increases the endorphin secretion. See, if you simple yoga, if you do simple exercise, that also alleviate the pain. Because not all the dysmenorrhea are pathological. Sometimes if you are stress busters or helpful. Many people you can see they will be drinking Coke, they will be drinking soda, they'll tell I felt happy. See, whenever the endorphin released naturally from the brain, the pain will go away.
Ma'am, what are the risk factors, ma'am, for this dysmenorrhea when it comes to adults? What will be the risk factors?
Mainly family history. Whenever there is a family history, it will run in families. And secondarily, the problem is thing is sometimes primary dysmenorrhea they will ignore. Some uterine anomalies might be there. So that's why we have to consult a doctor. You have to tell it is primary or secondary after consulting doctor only. See, whenever there is underlying disorders like any chocolate cyst, even adolescent girls nowadays we are seeing chocolate cyst and we are seeing any uterine anomalies, that could be the cause for dysmenorrhea. But if you can't find out any cause, we'll treat as a primary dysmenorrhea. We'll give simple NSAIDs. If not, we'll give some hormonal pills for them.
Okay, ma'am. Whether this BMI, ma'am, BMI plays a role in this dysmenorrhea, ma'am. Any risk factor is there?
BMI plays a role in PCOD. So many a times polycystic ovaries, the people who have high BMI, they'll develop polycystic ovaries. They'll get lots of hormonal disturbances.
Okay.
They won't have regular periods. They'll have irregular cycle. They'll bleed only once in 2 or 3 months. Whenever they are bleeding, they'll bleed more and the pain will be more. So indirectly might be for PCOD, but for dysmenorrhea, we can't correlate BMI and this pain. Only BMI is for high correlation with the polycystic ovary. And also what are the sanitary pad nowadays they are using is a dioxinone containing that aggravates endometriosis. They have found a recent study. Because of that sanitary pads, many cases of endometriosis have come up. So whenever there is dysmenorrhea, we will suspect some amount of endometriotic spots. Even though there is no identifiable cyst in the ultrasound scan or laparoscopy, we see many times when we are doing cesarean or when we are doing some other surgery, we'll see some spots. That see many a times we can't cure everything. So some spots we will see, we will like correlate with that endometriotic spots would be the cause for the pain. But many a times you can give some medical treatments, hormonal suppression to suppress the pain.
Ma'am, is this a growing concern, ma'am, whether in the past and the future, whether it is the cases are getting more, ma'am, or what is your opinion, ma'am, on your practice?
Actually, growing concern in the sense before and all, you can see ladies first 3 days they will sit and take rest. They won't go anywhere. They won't even go to school. They won't go to work, and they will make the girls sit in a place to take rest. So they won't come out with pain and all. They'll be sleeping. They won't even go for cooking and all. But nowadays, what happens is every other lady is going to school, college, work. So in such a case, they have to take any painkiller now. Previously, just by taking simple rest, they don't come to hospital. Nowadays, any adolescent girl comes with pain, I will tell her, please take mefenamic acid, go to work. Why? It's not, as we think, it's not that harmful. See, 1 or 2 tablets, if you take, nothing will happen. And also, they are going for work. See, nowadays, girls have become equal to male. They're doing all the work. See, they are going for all sports activity, academic. How can you expect her to do all the work with the pain? So obviously, she will take some NSAIDs, whatever, and the pain subsequent, she will go on to all the routine works, swimming, playing, sports activity, everything they are doing. Just because it is periods, they are not stopping that work. That's why you are coming to know that dysmenorrhea is there like that. Otherwise, it's same only. It's not incidence is same. PCOD definitely I can tell it has increased from before to now.
Coming to this oral contraceptives, is that all oral contraceptives is safe, or whether any particular progesterone or estrogen, the type of oral contraceptives is recommended?
Whenever adolescent girl, we give as low as possible dosage. The ethinyl estradiol is a estrogen content in the oral contraceptive pills. As low as possible, 20 microgram is the mini pill. More than that, normal is 30 microgram, higher dose is 50. So based upon the BMI, we calculate the dosage. If you want to give for PMS and simple dysmenorrhea, lowest possible dosage, Femilon like that, it is available. Or else little bit normal pills, Novilon like that. So we'll give the oral contraceptive pills according to the BMI and as low as possible dosage will be. Even though many combinations are there, only specifically if a girl is having acne and having PCOD along with that, then we prefer some other like pills like drosperinone containing pills. So PCOD and all, instead of levonorgestrel and norgestrel, we prefer drosperinone, like that we will prefer, because that is a treatment. It decreases the LH levels also. If it is associated, and also an example, endometriosis dysmenorrhea, we'll prefer dinogestone containing pills. So dinogestone containing pills for endometriosis and drosperinone, that kind of, or crimson like some cyproterone acetate. So that kind of pills we prescribe for PCOD. Simple adolescent girl, if she comes, lowest possible low ethinyl estradiol, levonorgestrel, desogestrel. That is the thing we are giving.
Okay, ma'am. Ma'am, there is no other questions in the chat box, ma'am. Ma'am, if you allow us, then we can end the webinar for today, ma'am.
Yes, sure.
Yeah, ma'am. Thank you, ma'am. Thank you very much for spending your valuable time with us today, ma'am. Thank you for accepting an invitation and for being with us today, ma'am. That is the first way. Thank you, ma'am. I'd also thank my audience who have joined here, and thank you, audience, for your active participation. If you have any queries, you can mail to us in the chat box. Then we can send it to the doctor, and you can get clear. So thank you, ma'am. Thank you once again, ma'am. That was a wonderful session once again, ma'am. And we are looking for many more interesting webinars with you in the future too, ma'am. We will reach you for any new updated topics. Thank you, ma'am. Thank you very much.